Well, I think it's important to recognize the power of Ibrutinib, in this particular setting, because whether it's in the frontline setting or in the relapsed refractory setting, we're seeing high response rates. We're seeing responses even in patients that have been previously treated, regardless of the number of prior lines of therapy. And really the art right now is being able to integrate, what we know about the genomics of the disease into how we manage patients on drugs like Ibrutinib. For instance, if the patient has a MYD88 mutation, that patient will do well on a BTK inhibitor like Ibrutinib. If the patient also has the second most common mutation, which is CXCR4, what we see is the response rates tend to be lower, and it takes longer for responses to occur. Now, that's important for clinicians to know about because it's a matter of patience, and early abandonment is what you don't want to see. On average, the time to get a deep response with somebody who has also a CXCR4 mutation is about 7 months, versus 1 to 2 months if they don't. And so that lag time, it's important for clinicians to know that these patients may eventually respond and that it's a matter of patience. And knowing the underlying genomics will help that. And the real issue is those patients that do not have a MYD88 mutation or a CXCR4 mutation. We call them wild type, double wild type. And this is really the problem group because now understanding the underlying genomics, we know that a lot of their signaling takes place below BTK. And so our ability to innovate new therapies and address their needs is also important. I'll bet that this is still a relatively small population of Waldenström's patients. And how we integrate I versus I plus R, this becomes the art. For patients who particularly have CXCR4 mutations, the addition of R may be important in order to help accelerate their response. And hopefully this year we're going to be hearing more data on time to response at the American Society of Haematology meeting.